Hi, this is a ADC part 2 video, not part 1. So if part 1 candidates want to watch this just to get an idea about how a communication OSCE is going to go, they can watch. If not, skip this video. Uh, I usually don't make OSCE videos, but I had a special request from one of my previous candidates who cleared his part 1, and he requested if I could record some of the OSCE cases uh, because if you're a part 2 candidate, you know, there are different mentors teaching various things. But what I've noticed is even when I was giving my part 2 exam in communication OSCE, a lot of hype was made so as to do this and do that. And a lot of information about each case is provided. Uh, First thing is that you are not supposed to vomit out dental knowledge in front of the patient. Some students, actually, a lot of students try to mug up a lot of information, and it seems more like you are trying to, vomit out all the information in front of the examiner just to show that you know dentistry. No, that is not the purpose of a communication OSCE. Yes, you need to know your subject, but you are not supposed to like just keep on giving on information in order to cover and say as much as possible. No, you have to see the situation and appropriately say things in a very calm, composed tone and just enough information to make the patient understand his situations, etc. Like how you would speak to your own patient in your own clinic. You have to be that relaxed. But people stress out and they think the whole 10 minutes they are supposed to keep on just blabbering, even of the stuff which is not important. So that is not going to help anyone, honestly. Uh, what I'm going to do today is I'm going to act out a case and I'm going to myself time it for 10 minutes. So in the exam scenario, so I've just set up here my stopwatch. I will start it when I will start communicating. I'll be only the candidate and I'll be only the examiner. When I'm the patient, I'm going to wear this cap, okay? Yeah, it's funny, but you'll get the effect of how the examiner speaks to you, you know? And yes, you can laugh. My life laughs on me, so you can also laugh. I'm up for it. So, anyways, if you are a part two candidate, you know by now that there are six communication OSCE stations. Room one and room two, they're all designated. Room one and one, two are information. Three and four are diagnosis, and five and six are clinical treatment evaluation. Uh, Key rules, I'm giving this in very brief, short summary so as to not make a long video. Assuming you as a part two candidate already know about this. Uh, Try not to waste too much time on information gathering in room 3, 4, 5, and 6 because that is not the information gathering. You have to manage the patient more. Always read the question properly. And in all the six rooms, you as a candidate, one thing you have to make sure to clear this communication OSCE. Firstly, make eye contact. Don't be shy, afraid, or be nervous. Make eye contact. Second, be empathetic, not sympathetic. Be kind and empathetic and have a very normal tone. Third, listen. Don't just keep talking. If the patient starts talking, listen. Don't try to finish off your sentence, okay? And say thank you. You'll see where all I'm saying thank you. And yeah, pretty much. And yeah, one last thing is that is if required, if you are in these four rooms, whatever treatment planning you will give to the patient, always tell him that he can think about it and then both of you together can make the decision jointly or together. Okay, don't like force it on the patient that you have to do this. You always tell them that we can mutually decide then what is best for you and we can go ahead for it. So remember these 4 or 5 points that I've told you. If you want rewind the video and listen to it, write it down. If these things are not there, no matter you have given the best possible diagnosis, the best possible pathology, it's very difficult for you to pass, because they are not just testing your dental knowledge, they are also testing you as a clinician. How much are you trying to make the patient comfortable, and being humble, and have humility in you. You understand? And these qualities are really important. Uh, this part is very good clinically, which I myself practice in my own clinic, and a lot of good doctors I have seen practicing the same thing. So these things in the exam also and in your clinic also. So this is one good part about the part 2 exam, which I really like. So anyways, how to help you all with it? I know a lot of notes you must be having. There are 67 cases and tons of pages. How do you remember all of it? So what I had done is, I'm going to show you something now. I have just taken, I was writing it, and I will share that thing, and you can paste it, copy it, save it, whatever. So let's start. Let's give us 3 minutes in exam also. When you'll enter the room, 3 minutes would be for you to read the case, and 10 minutes would be there to discuss. Now in those 3 minutes, finish reading your case in 1.5 minutes, because you'll see where your 1.5 minutes, the rest of it will go. So let's start. Now I'm the candidate, I have entered, and the examiner is just sitting, and the screen is on the left, so I actually have to turn like this, it's not like behind or something. So I have to turn like this, and I have to read it. And sometimes, if the cases are big, it takes a while, but try to finish it. There'll be a case and there'll be a radiograph. Now, suppose I've entered room 5. I know this is clinical treatment, or I've entered room 4 for this case. I know it's a diagnosis, management, and cluster. So, probably either the diagnosis is given or it's leading me towards it. Okay. So, let's start. Mr. Davis, a 50-year-old medically fit patient, visits your practice. Okay, he gives he's medically fit. So I have a pen and paper. Okay, I immediately write medically fit, like short forms. He gives a history of multiple amalgam fillings placed over last 15 years by his previous dentist. He has no fractured restorations, no pain, and no sensitivity in any of his teeth with amalgam fillings. Fair enough. He's just concerned about the mercury poisonings in which he read in some of the articles, and wants to replace them with white fillings. Manage the patient concern. What is the concern? The mercury poisoning. So fine, I finished reading. Now what I do is, I have a pen and paper, and I immediately start writing the initials. So you see, I have underlined here I, C, E, H. Please remember them in the same sequence. Make a antonym of it if you would like. And then in the history, I have further outlined it as C, P, M, D. I'll tell you what this is. See, on the paper, when I have the guidelines, then my speaking to the patient goes on very smooth. So now I'm just going to open this, and I'm going to hide the question. So imagine this is what I have on my page, and I've really quickly started writing ICF. So I know I is for intro, CF is for chief complaint, empathy then in between, and then I have history. Now I have divided history into further the chief complaint history, the pain history, the medical history, the dental history. And the medical history, I further divided into medication and diseases. So I'll write the short forms. So I have this booklet in front of me, and I have already outlined the steps in which I'm going to start communicating with the patient. If I don't write all of this, I mean, I'm telling all this to you because this method worked for me. There can be various methods which can work for you, figure that out. But I'm sharing my method because I found this very easy, because then I'm pretty much covering everything, and I'm not forgetting or stressing my brain. Oh, I have to remember this while I'm talking to the patient. You understand? I can't do both. Plus, there is exam pressure, plus, there is a clock ticking, and it's not like it's going to be a one-way conversation. The patient might interrupt me in between, and I might just forget what I have in my head. But if I have written it down and I have a pencil in my hand, I'm just holding on to that point, and I won't move. Even if the patient interferes, I will just keep my hand over the point, and once the patient has asked me something and I have answered it, I move on to the next point. So I'm covering all my points. You understand? Yeah, then social. So I've written here in full words here so that it's easier for you. But I've also made an antonym here, you see, SASD, that is stress, alcohol, smoking, drugs. So I just write on my notebook this, but for you all, I have written in detail so that you understand it for the first time. Diet, I've put a question mark because depends. I have to ask or don't. I will not ask irrelevant stuff. Okay. Now, because I know this is diagnosis management or clinical cluster, I'm not going to waste more time on the history. And most of the history is anyways provided in the question. So it's actually a waste of time if I put more on the information gathering. And the next page is this. So I used to almost take 3 pages. I used to write like at the initials very fast because I know I'm going to tick 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 all of them. Manage concerns, and here again empathy I've written E. And then validate reasoning. Reasoning is you providing your logical scientific explanation to staff, and you also have to pause in between so as to give the patient a chance or just to see if the patient is listening to you. If you just continuously keep talking, you're not talking to a blank screen. There is a human in front of you, and you have to make sure that the person is understanding. Sometimes you may have 10 points in your head, but if the patient is asking a lot of questions, you may not be able to cover it. Fair enough. Answer whatever question the patient has asked very nicely so that he understands that. I mean, you of course cannot finish everything in 10 minutes. So you have to finish sufficient and enough things which is required for that particular moment. You understand? And then the management part will always have pros and cons, or a short term and a long term management. Always it will be divided into two. Okay. So assuming now that I have written all this down, my 10 minutes start. Let me on it now. So I'm the candidate. I'm sitting. Hi, I'm Dr. Garima here, and thank you for coming in here today. I see that you are very concerned about some amalgam fillings which is present in your teeth, and you would like to have them replaced. But before proceeding, can I ask you a few more questions about it? Yes, doctor. I have this fillings since a long, long time, and recently I was just reading onto some articles, and I was doing my internet research, and I found that mercury, if you have them in the mouth, they can be really damaging and toxic, and I'm really concerned about my health. So I really want to get them replaced. Doctor, please do something about it. Remove it and make them all white. Yes, I understand that you are very, very concerned, and I can see from your history that you're medically fit, which is good for you. Let's talk about it. But before we actually do something about it, I really want to make sure that we are on the right path. So, is it okay if I ask you a few questions about it? Yes, please ask. So, do you feel any pain ever in your mouth, like dentally, where the fillings were done, or otherwise? No. Do you ever had any diseases or are you taking any medications? Though I see that you have written that you're very medical fit, and that's very good to know that you're taking good care of your health. I've always been fine. I never had to take a medicine, and I keep on visiting my general practitioner regularly. That's really good to know that you take good care health. So may I ask when were these fillings done, and how do you maintain your oral hygiene? Somewhere in 15 years ago, and I brush my teeth twice daily. That's again good to know. And just a few more questions. Thank you for your patience. So, do you think you're under stress, or and do you have any habits like smoking, drinking, or some recreational drugs? I smoke occasionally, drinking once in a while, but off late, no stress. I'm pretty much good. Well, that's good to know. And did you ever have any swellings like intraorally, like inside the mouth, tongue, gums, or extraorally, like on the face or the cheek? No, never. Thank you for answering all this thing for me. Now coming to your concern, may I ask if if the fillings were there since past 15 years, why the sudden need to change? I understand that you've read some articles, but is there anything more to it that you would like to tell me? Yeah, I was reading some articles, like I said, but I also have a partner, and he feels that they don't look good either. So, I don't want to displease him, and I'm myself concerned about the health of it. So, I think it's a good decision to get them replaced. So, tell me, doctor, how can we do it? I understand your concern. I understand your partner's concern as well. Well, I would like to explain to you that the amalgam fillings that we do have been always practiced in dentistry like since almost 160 years. I understand your concern is that a lot of fillings are toxic, but mercury in its free form is toxic. The mercury which is placed in your teeth is in a fixed form. It's already been formed, and the vapors are only released when you place it or when you remove it. Right now, it's in a very stable form, and it's not releasing any mercury that can cause any toxicity. And even if it did, it would be such a little amount that can be easily eliminated by the body through your kidney and urine. So actually, you don't have to be worried about it. Also, if it was so toxic, then the Australian Dental Association and the NHMRCA, which is an association which manages all these things, would have never approved about it. But in case you still wish to remove it, I can explain you the protocol. We do it very diligently, and we maintain all sorts of protection. We will use an umbrella kind of a sheet, which we call it as rubber dam. We will place it around your teeth, and then under proper mask and enough ventilation and high vacuum suctions, we would be removing the amalgam fillings, and then we'll be doing the white ones. But before you choose to do it, I would like to also inform you about some pros and cons of this procedure if you are happy to know about it. Yes, doctor, please tell me. I understand that you told me that it's not toxic to me at the moment, and that is such a relief to know because I was getting scared. But yeah, please do tell me as to how to go about it. Sure. See, of course, after removing the amalgam fillings, we can do the white ones and they would really look nice. But removing the amalgam fillings may also cause pain and sensitivity. In few of your teeth that I can see on the X-ray, the amalgam fillings are really huge. Sometimes removal of such huge fillings can lead to microfractures in the tooth, which eventually can lead to the death of the nerve, or sometimes the tooth can also fracture. It's not I don't mean to scare you, but these are the things that may happen. Also, it's going to cost you a lot more by removing all these things and putting a new one. So if your concern is just about the toxicity, then I would like to give you some brochures and few links which you can see and read more about the safety of the amalgam fillings. And if you yourself are okay with the aesthetics of it, but your partner is only concerned about it, then I would suggest that before you make this decision of removing the fillings, why don't you get your partner along and we'll again have a discussion, and I'm happy to explain him all the pros and cons and how we deal with such things, and then together we can make a decision about it. Yes, doctor, that sounds like really nicely. But doctor, would you be giving me any anesthesia, or, I'm very phobic about the needles. Would that be required for my situation? Normally, for small fillings, we generally tend not to give the local anesthesia, but yes, if it's a big filling, then we would prefer giving you local anesthesia. I understand that you are having fear about it, but you don't have to worry. We have methods like nitrous oxide sedation. We can speak to your general practitioner for some other oral sedatives, which are mild, which can relax you, and which are kind of anxiety relieving. And then we can go about the procedure, and of course we are there to guide you throughout the procedure, so you should not be feeling that much of scariness. But let's just first get another meeting done with your partner and then decide whether you would like to go ahead with it or not. And in the meantime, you can read more about the amalgam toxicity and then make your decision, and we are always here to help you out. Thank you, doctor, so much. So I'll come again with my partner. Thank you. So yeah, there goes my 10 minutes. It's done. Like barely have how many seconds to left? I just have like 30 seconds to go. So yeah, pretty much. It may happen that the examiner is speaking a lot, which leaves you with a less time. So always have like a minute or more, and then you can of course keep on talking more about it if you think you have a minute or more left, you know. Otherwise, it's all right to stop if only 30 seconds are left. Like you don't have to continue to the last dot. So I hope you pretty much, I mean, this is also my first time explaining this up and down types, like being the examiner and being the candidate myself. But you pretty much got how I spoke, right? I was never too fast, I think. Uh, I was direct, confident, uh, just enough gaps in my words to make you understand, wasn't hyper. So, as it is when you're under exam stress, your heartbeat is more and you get tachycardia and you tend to go a little faster, and that's why you have to calm yourself down. And you barely have a break of 5 minutes before you move to the next station. So, immediately when you come out, have a glass of water. They have the water dispenser right outside the rooms, and you will also have the skilled OSCEs going on. So, for me, I had so there are 10 stations, right? So after 5 stations, I got a break of 15 minutes. And then, so it was back to back, back to back. Uh, so, yeah, I hope this helps you. And there are tons of notes available with your mentors, I'm sure. 5566 pages of what to speak. Don't mug up. Follow, if you have your own method to follow, go with it. But if you don't, then the initials that I mentioned on this handwritten thing, follow that. It's pretty much a lot of things that you can cover. uh, I would spend more on the information. If it was the information cluster, then I would have a little more in my initials of basically the asking question part, if it was information gathering. And when we will do an information gathering cluster OSCE, you'll see the changes in my this sheet. You'll have more of information gathering. You'll have more on the investigations that I have to explain. But here it was basically managing the patient concern, okay? And because he didn't have any pain, sensitivity, etc., I didn't have to dig into various things, and already an X-ray was provided to me. So this is pretty much how a communication OSCE will go. So write it in your comments how you felt, and if you're first time watching how communication OSCE is, welcome to part two. And I don't have cases honestly. So if you want, because apparently uh, the other mentors, whoever are there, are not so generous as me. For example, for my part one candidates, I don't disconnect the candidate if they have failed and ask them to pay again. Like basically, I don't kick them off the drive that I've shared. I let them have it until they clear the exam. Uh, but the other mentors, apparently, when you attempt once and if you don't clear the exam, they kick you off the online drive thing. And if you want to appear again, you have to pay the entire amount. So anyways, if you have cases and you want me to do communication OSCEs on them, you can just email me. I'll write the email address and my link. I'm happy to do, if my time permits, as many videos like this if it helps you out. So this was on amalgam toxicity. So there. Bye bye. Good night.